Huh?
Everything but YouTube.
It took YouTube a minute. Hi, everybody. I am Dr. Rahi Victory. Welcome back to Fertility Fact or Fiction for the new year. So this is our first show of 2021. Happy New Year to everybody. I hope that you had a safe and enjoyable holiday. I feel terrible for all of the youth out there and the adults who were hoping for some relief from this pandemic and an opportunity for a good time. But unfortunately, that was not in the cards for us. So we are hopeful that you enjoyed yourselves nevertheless, had time to be around people that you love and care about, and enjoyed some quieter time than we traditionally have in the past. And we're safe. God willing, everybody is still doing well. You have not contracted this terrible virus, and things are going okay. So we are trying out some new technology tonight with a new software package. So we're working out some of the kinks. We started a few minutes earlier, and now we're back up and running again. And hopefully we'll be able to see all of your comments on the one screen that we're using. And I no longer have a laptop in front of me, which I traditionally do. So this should be an interesting experience for us. Want to just quickly address the fact that in Ontario and in Canada, the OBGYNs have been somewhat up in arms about the fact that so far the government is holding back on providing the vaccines to pregnant and or breastfeeding women. So people have been asking us this question about whether or not it's safe in pregnancy, and the answer is we only have surrogate markers right now of whether or not it's safe in pregnancy. So what are those markers? The markers are that, number one, we know that women that have contracted COVID while pregnant have not experienced a higher risk of miscarriage. So this has been looked at. Admittedly, the numbers are small, but no one has demonstrated a higher risk of miscarriage. There is some suggestion of preterm labor, maybe that the babies are a bit smaller, but certainly no risk of miscarriage. So in terms of complications, they do not seem to be overwhelming. There are maternal risks, pneumonia, ICU admission, hospital admission, problems with breathing, the typical problems everybody is having with COVID. But there are no fetal risks that appear to be significant from the infection while you are pregnant. And the vaccine would, in theory, induce the same immunological response and as such would cause the same sort of problem. So we are not seeing that at all with the actual infection, and therefore the vaccine shouldn't cause it. The other element that has been looked at is that approximately 30 patients who took the Pfizer vaccine either became pregnant or were pregnant but not detected when they first got vaccinated or took their second shot. And all of those were followed for the duration of that trial, and none of them demonstrated any significant adverse effects from having been vaccinated. So again, very, very small numbers. Is it possible there is something that will turn up later on? None of us know, but certainly based on the information that we have and the numbers that we have, there does not appear to be any reason why pregnant patients and or breastfeeding patients cannot take this vaccine. Certainly breastfeeding is almost certainly safe. And from the standpoint of pregnant patients, it's most likely safe because we're not seeing any harm from the actual viral infection. Now, I had a, shall we say, lively debate with a Instagram individual who was clearly anti-vax, who believed that she knew all the answers to the vaccination questions and had already done all her own research and knew everything about the trial. Unfortunately, that individual and many individuals are simply promoting false narratives and information about the trials in an attempt to either scare people or drive you away from the vaccination. None of those claims are true. So these trials were randomized double-blinded trials for both vaccines, the Moderna and the Pfizer vaccine. Yes, I'm sure people at Moderna and Pfizer made millions of dollars from working there both before these trials and maybe even during or after these trials. And quite frankly, why wouldn't they? They are hardworking individuals like any of you and myself, and if they're entitled to stock options and it's an opportunity to take those stock options, they're going to. Having said that, it had absolutely nothing to do with the data that was analyzed because the Moderna trial in particular had its publication released by the Data Safety Monitoring Board, and they had nothing to do with Moderna. They were members of the study group, none of whom worked for Moderna. So all of these claims that it's all about money are not coming from science. They're coming from a desire to kind of sabotage this whole vaccination. Why you would want to sabotage this, I don't understand. The other claim this individual made was that it only saved 30 people from getting severe COVID virus, which was just like egregiously ignorant. So the reality is 14,000 people were spared from getting COVID permanently, and 14,000 people remain susceptible. Yes, in the 4 months of the Moderna trial, about 200 or just less than 200 people actually contracted COVID in the actual placebo arm, but those people were just 200 of the 14,000 in that time frame. As time goes on, A, those people spread it to other people for sure. We know that this virus spreads, and very quickly. And B, the other 14,000 people that didn't get the actual vaccine, they got the placebo, are still at risk for getting COVID. So there is a time element built into this, which is critical for people to understand. So the vaccine does appear to be safe. Certainly for non-pregnant, non-breastfeeding people, it is. For the patients who are breastfeeding and or pregnant, it is probably safe. We have no evidence to indicate that it is not. And certainly if you're in a high-risk category, you're a frontline worker or you're exposed to patients who have COVID or you're in long-term care, you definitely should consider getting vaccinated. And I believe as well, along with the rest of the society in Ontario and Canada, that it makes a lot of sense for those patients to be included. And to the best of my knowledge, they are considering running the trials on pregnant and breastfeeding patients very soon, because we were actually invited to participate in that, but we have not heard back yet whether or not we've been selected as a site. So I think that there is real potential for that to occur, and we are excited about that potential. I do agree that everything merits investigation and study, but the reality with all of this is that we need to see what the data shows. And until then, we need to make our best guess, or a most educated guess that's possible. And that educated guess is that it does appear to be safe. So with that, I hope that that makes sense for everybody. We have a little post on that already on Instagram and YouTube, and hopefully you guys can follow that. Make sure you like, comment, and subscribe. That's always important for us to help us grow and help us do better. So tonight's topic is one that I found quite interesting, because we wanted to see if a previous history of a poor response during a stimulation cycle or an IVF cycle actually predicts your chances of having a poor response in a subsequent cycle. So obviously, a lot of people don't stop at just one try. If they fail the first time, either because they're insured or they can afford it, or they just have that desire to continue trying and the ability to do so, they will try multiple times. And so the question was, what if you don't do very well in your first cycle? Does that predict how you will do in a subsequent cycle? And the answer to that question came from a new study, which actually is as yet unpublished. It's still in proof, but we get access to that with the access I have through the library system. And I wanted to share that with you. So it's a study coming from Bourne Hall, which is actually the original IVF facility in the world. The first place IVF was done in the UK. And they actually analyzed 1,224 patients to see if their previous history of a poor response was going to be predictive of their subsequent response. So in other words, if you didn't do great the first time, what was the chance that you were not going to do well the second time? And then they went back and analyzed it to see if there were specific factors which were significant in terms of determining whether or not you would have a predictive value in the next time of doing poorly or doing okay. So they took 1,224 patients, they studied them over a couple of years duration, and they collected as much data as they could on these patients. So this is actually a fairly brief talk with you guys tonight about this, because the first and quickest part of this is that I'm sure you all want to know, what were the criteria for a poor response? Super easy. They said just less than 3 follicles or 3 eggs retrieved, and it was less than or equal to 3 eggs retrieved. then they said, okay, that was the definition of a poor response. So if you had 3 or less eggs, they said you didn't do well enough. That's considered a poor response. And then the second part of it was, did they have any exclusions? And they did, but their exclusions were all very reasonable things that they looked at. And certainly when the study comes out, I can refer you to those. But they were, for all intents and purposes, very appropriate things that they considered for cases that they would exclude. So the next part of it was essentially what percentage of patients did poorly a second time around if they did poorly the first time. So you made 3 or less eggs the first time. What was the actual percentage of patients that did poorly the second time around? And the answer to that is, out of that 1,224, only 141 or 11.5% did poorly again the second time around. Now keep in mind, some of those patients only made 4 eggs the next time around, but some went on to make actually more than 15. So it's a very interesting study in that there are times where you can do quite poorly the first time and then do well afterwards, and actually it looks like 88.5% of the time, an overwhelming number, you are likely going to do better the second time around than you will the first time. So this is very, very valuable information. So then they went into it in detail and said, okay, let's kind of look at a sort of assessment of what factors were important. So number one, they looked at age. So if you were less than 35, only 33% of the patients had a poor ovarian response in a repeat cycle, whereas 56% of patients were less than 35 who did fine in the subsequent cycle. So if you had poor ovarian response the first time and you're less than 35, there's only a 33% chance in that age group that you were going to have a repeat poor cycle. For the patients that were 36 to 37, it was 31.2%. And for those that were 38 and older, it was a little bit higher. It's up now to 35.5%. So about a third of the group that had a poor response was in each of those age groups. But it's also important for you to know kind of where that breakdown is. Body mass index was actually not a factor, so it didn't matter how high or low your body mass index was. It did not contribute to your prediction for doing well or poorly the second time around. And that's really important because we've talked about the predictive value of body mass index on your cycle outcomes, on your frozen embryo transfer outcomes. It is definitely important on doing any kind of fertility work. But in this particular case, if you did poorly the first time, regardless of whether your weight was high or low or normal, it had no impact on whether you were going to do well or not the second time around. They looked at the cause of infertility, whether it was male factor or female factor. Again, that showed no significant difference. The big one was whether your AMH levels were low or high. So if you had an AMH level that they considered low, which was less than 5.4 picomoles per liter, and that's in the decimal range for those of you that use nanograms per mil, then 41.8% of the patients with poor ovarian reserve had it again with, poor ovarian response, had the same thing happen again in the repeat cycle. So if your AMH is low, it is highly predictive of the fact that you will do poorly again. And that's compared to just 7.8% with that same AMH who did better in the second cycle the next time around. If your AMH was average, which they classified as 5.4 to 25, 49.6% had a repeat cycle that was poor versus 55.5% in the non-group. And then if your AMH was high, only 8.5% were in that group that had poor ovarian response in the second time around. So again, it looks like your AMH is highly predictive, and this had previously been shown as well, and that makes a lot of sense. In fact, arguably, if your center knows that you have a high AMH and they're moving forward with your cycle looking like you're only going to get 2 or 3 eggs, that's actually one where we would typically stop the patient and say, listen, you're not doing as well as we would predict you to do. As long as your meds are covered, we should be stopping this, restarting again, figuring out what went wrong, and then beginning the process, because it is truly unfair to you to have to go through all the shots, all the cost potentially, all the meds costs as well, and then the egg retrieval, which certainly is never 100% comfortable during or after, or even before, and then have to endure that to get 3 eggs when we know you could potentially be getting 15 or 20. So clearly that's a really important thing for us to know about. And if you have a high AMH and you are not doing well, this study is actually telling you that you should probably abandon ship, so to speak, because the next cycle around should do much, much better. The number of eggs retrieved was also highly significant. So if you had less than 3 eggs retrieved, that represented the majority of the group in the poor ovarian response in the second cycle. 4 to 9 had a medium kind of number, and if you had 10 to 15 or over 15 eggs, then clearly you were going to do much better the second time around. So those patients, who had a reasonable response initially, were going to have a reasonable response later on. Now, the quizzical thing with that is they actually said their inclusion criteria was less than 3 eggs, so I'm not sure where these patients with 10 to 15 came from. They don't really delve into that in this study. The patients who actually had an embryo transfer from their first cycle had a reasonable chance of having a poor ovarian response still, even if they had a embryo transfer from the first attempt. So getting an embryo transfer does not necessarily predict whether or not you will do well in a subsequent cycle. They also looked at things like embryo freezing. Again, highly significant. So if you had embryos to freeze, you probably had less likelihood of having poor ovarian response the second time around. And then the interesting thing that was very fascinating for me was actually they looked at how long it was from your first cycle to your next cycle. And they compared less than 1 year and greater than 1 year. And again, there was actually no statistically significant difference. So obviously a lot of patients who do poorly get panicked. They think they got to go again and again and again. And we've shown you a study before which showed that even up to a 6-month delay made no difference. This study is actually saying that potentially even up to a year is not making a difference. So very valuable, important data. The other thing that's critical is that even in that group that had a poor ovarian response the second time around, the ongoing pregnancy rate per cycle was 21.3. And in the group that actually didn't have a repeat of the poor ovarian response, it was 37%. So that is a very, very important number, because this says that even if you don't do well with one or the other cycle, you can still ultimately get a reasonable pregnancy rate, maybe not high, but a reasonable pregnancy rate, which gives a lot of hope to those who are struggling and really trying hard but not getting the robust numbers that they want. So I always say it's not all about the numbers. Numbers are important and you have to understand your numbers going into it. But keep in mind, statistics are just statistics. So you have a 1 in blank chance of an event occurring. It doesn't mean you won't be that one. So somebody is going to be that one, and maybe it will be you. You just have to feel comfortable with that chance. So if I told you you had a 10% chance of winning the lottery and it's going to cost you $10 to get that 10% chance, you might feel comfortable with that. Versus someone that is told that they have a 1% chance of winning the lottery and it's going to cost them $1,000, maybe now they're not as comfortable. So as long as you know the numbers and you can make a decision for yourself, that's perfectly fine. So the authors then went on to create an actual graph where they looked at the predictive value. So in terms of what's the fold of risk or chance that this will make a difference for you. So if your AMH was low, you had a 3.54 increased risk of a poor ovarian response the next time. So in other words, a 250% increase in your risk that you're going to have a poor response second time around if your AMH was low. And conversely, if your AMH was high, you had a 64% reduction in the chances of having a repeat poor response. So again, that AMH value looks very, very important. In terms of the number of eggs, if you had less than or equal to 3 eggs in that first retrieval, then you are going to have a 14-fold increased risk of having less than or equal to 3 in the second. If you had 4 to 9, it was still a 4-fold increased risk. And if you had that higher number where you're over 15, it was drastically decreased, almost by about 70%. And then they did relook at the time between treatments, and they did on secondary analyses when they plugged it into this equation accounting for all the factors, find that there was a little bit of a difference when you're waiting more than a year. So if you're repeating your cycle within a year, they used that as the reference. And when they compared to that in this secondary analysis where they controlled for all of the risk factors, they actually said that maybe there is an increase in risk of failure, and it's almost double. So waiting too long may have an impact, but certainly within a year, it is not a problem. If you're waiting more than a year, it may lead to some complications. So they actually developed this predictive sort of graph, and that predictive graph is really important because it actually calculates something called the area under the curve, which is a sensitivity versus a specificity plot. I won't bore you with the statistics, but the closer it is to the number 1, the more accurate this model is at predicting your outcome. So anything at 0.5 is a straight line across the graph, and what you want is like a complete inverted L shape where it's very sensitive and very specific. So what they got for this graph is a curve, which is typically what we get, but it's 0.83, which is actually exceptionally good. So this is a very predictive model, and they then took that model and they applied it to a real-world group prospectively, and it still held pretty well. Not quite as strong, but still over 0.7. I believe it was 0.73. So that's still a pretty strong model in terms of predicting your outcome. So is it true that a previous ovarian response can predict a poor response, can predict a repeat poor response? The answer is some of the elements of your history can help you predict it, but it's actually mostly false because only 11.5% of you will actually go on to have a repeat cycle where you're not producing very many eggs. So there is a lot of hope moving forward that if you do repeat cycles, there is a chance that you can hit that golden egg and end up with the desire of having a baby fulfilled. And so that's really, really hopeful, important information. So thanks for joining us for the Fertility Factor Fiction Show. Make sure you like, comment, and subscribe. It's critical for us to help grow this for you so that we can reach as many people as possible and bring this valuable information to them. We're going to go on to the question part of this show now, and Tarek's going to be reading them because I have no ability to read them anymore where I used to before.
It's insane.
Is it insane? No, it's insane apparently. I'm going to have a sip of tea, so Tarek, fire away.
Start with Instagram?
Sure.
Okay. So, all right. Hi, I have low AMH and did 4 rounds IVF, ICSI, and no embryo. I had about 4 eggs each time, but just mature egg, and it stopped at 3 cells. What's your suggestion?
So if you've tried 4 times and each time you ended up with just 4 cells or 3 cells or something very, very early like that, the first thing you need to do is take a look at the sperm quality as well. You need to check out your lab to make sure that the lab is doing everything correctly. And you also need to make sure that your lab has good results in cases like yours. Assuming your lab is fine and the sperm is okay, that would certainly be a fairly clear indication to move on to a donor eggs scenario. Because if you've tried 4 times, the likelihood of yield beyond that is going to be very, very low. So I would not recommend you do that. You should probably jump right from where you're at already into a donor egg situation. Now, if you find out that your lab is not ideal or not optimal, or maybe your stimulation was not ideal or optimal, and a second opinion is definitely where you want to start for this, then that's a different story altogether. And we have loads of patients that see us for a second opinion where I realize something wasn't quite right the first time around. I can tweak their protocol. We can get them past that previous poor response or poor outcome, and we can do better for them. So you need a second opinion. That's what I would recommend to you. I do think you need to be open to the idea of using a donor.
Is jumping safe during the 2nd trimester?
Is jumping safe? No. I mean, I would be jumping. I don't know why you'd be jumping. I mean, if it's a little jump because you have to, sure. But if you're doing parkour in your second trimester? No. So no, we certainly don't recommend people jump up and down. The placenta is attached to the uterus not very solidly in most pregnancies. So while it's firm enough to endure most kinds of activities, it is not firm enough to endure trauma, and placental abruptions, where it lifts away from the wall of the uterus, can happen quite easily and quite commonly from something as simple as a bump into something or a car accident, or sometimes, unfortunately, domestic violence and so on. So I wouldn't recommend you be jumping.
What is the step-by-step process of an FET at your clinic after you get your period, i.e. shots and waiting time?
So we have a variety of different approaches to our FETs, and we don't believe in cookie cutter medicine, so I don't do the same thing for everybody, but for many of our patients, the protocol we use involves putting you on Lupron first to take over control of your pituitary, so you're not going to release your egg in the next cycle before we want you to, and we usually do that around day 21 of your previous cycle. And then around day 2 or 3, we'll bring you in for a baseline ultrasound, do some ultrasound and blood work to make sure everything's normal, rule out any cysts. As long as everything looks okay, you would start on estrogen, and that can be done either orally or vaginally, depending on your history. You can even do it transdermally. We also use letrozole, and letrozole we've shown on a previous fertility factor fiction has benefits to doing frozen embryo transfers. We then monitor your cycle, we monitor your endometrial thickness, we wait till it gets to around 8 millimeters, 9 millimeters, and then we begin your progesterone. We do monitor your progesterone levels, we monitor the contractions of your uterus, and we monitor whether or not the endometrium shrinks in response to the progesterone, which has been previously shown to have a significant impact on your outcomes, a very significant impact from a group in Toronto. But interestingly, there is a study about to be published which says that it makes no difference whatsoever at all. So now that one's up in the air as well. We do use some other supplements and medications. So we use melatonin. We've shown on another previous fertility factor fiction that melatonin can be beneficial. So you can look that up on the YouTube channel, check out our link. And we also have probiotics in our patients. We do use antibiotics prior to the cycle to make sure we're eradicating anything that might be in the uterus. We make sure you're on appropriate vitamins, so vitamin D, your omega-3 fatty acids, and then your prenatal vitamin. So that's essentially what we do for ours. We do use progesterone in oil and vaginal progesterone. We'll wait 5 days and then assess the lining. For a day 5 embryo, we transfer after 5 days of progesterone, although you can delay till day 6 as well. For a day 6, we do it on day 6 because, again, on a previous fertility factor fiction, we did demonstrate that it can reduce the chances of miscarriage if you go 6 days of progesterone and then do a day 6 embryo transfer. That's pretty much it. Wait 2 weeks and find out what your results are.
I'll take some from the other guys.
Actually, while you're looking, one other thing we do, which is very rare, and I'm proud that we kind of, sort of mastered in our experience, is doing a transvaginal ultrasound guided transfer. So for women that have a retroverted uterus, it is extremely difficult to see the uterus unless the ultrasonographer is just reefing on your tummy, which is not comfortable, and that is not the right way to do an embryo transfer. So we do a lot of transvaginal guided ultrasound embryo transfers, and you get an absolutely spectacular image. Your bladder doesn't need to be full. It's very comfortable. And even in the worst case scenario where your uterus is actually turned kind of 180 degrees around, we can get a beautiful view and see exactly where the embryos are going. So that's something that has been very instrumental to our success, and we are averaging 80% right now. So we are doing very, very well with those embryo transfers.
Okay.
Mm.
The first one on Facebook was, is there any evidence that the vaccine could cause infertility?
No. So we're going to get lots of vax questions tonight, I'm sure. So the reason that people said that the vaccine might cause infertility is that there are 6 amino acids in a row on the syncytin protein, which is a placental tissue protein, that are homologous to 6 of the amino acids on the vaccine sort of script from the RNA. The problem is that it's not the same region that's targeted, so that area of the syncytin protein has nothing to do with what the vaccine is targeting. The vaccine is actually targeting a separate segment, and the 6 amino acids on the virus that actually code for this same 6 amino acid sequence are completely in a different part from where the antibody that's going to be produced by the vaccine is going to bind to. So in other words, the coding for the vaccine does not code for those 6 amino acids. So there is virtually no chance that the antibody from the vaccine will bind to that region because it doesn't share that homology, we call it, or that sequence. So that's where it came from. Some lunatic who worked for Pfizer or something like 2011 said, oh, it's going to cause infertility in everybody, but there's absolutely not a speck of truth to that. And like I said, the actual virus itself does not cause an immune response that causes infertility. I mean, women who are having something attack a placental protein would 100% end up with some kind of problem in their pregnancy. And the reality is that has not happened. So we believe that it is safe. We don't know for sure. No one's going to, hang their hat on this, so to speak. But we believe that it is safe. And there, more importantly, is absolutely no evidence, theoretical or practical, to demonstrate that there is a risk of it causing infertility. So to the best of our knowledge, the answer is it does not cause infertility whatsoever. It just doesn't work in the same area at all.
Question for you, is taking melatonin, inositol, and probiotics while going for IVF allowed?
Yeah, so actually, as I just mentioned, we recommend all of those. So if PCOS patients or endo patients, inositol is great. We definitely recommend melatonin. It's been proven to be beneficial. What was the third one? Melatonin, inositol, and?
Probiotics.
Yeah, and we use probiotics for all our frozen embryo transfers. So yeah, you should use all of those. That's a great idea.
When does your funding for IUI return at the Windsor Clinic?
April. It's always April 1st because that's their fiscal year turnover. So IUI funding will resume April 1st.
What does it mean when someone is diagnosed with IUGR?
Oh, IUGR is intrauterine growth restriction. So we know how big average babies are, and there's a scale, and that scale, when you go below 10% growth, so in other words, if your baby is in the bottom 10 percentile, we call that small for gestational age. And when it's in the less than 3 percentile, then you're intrauterine growth restriction, which means the baby's actually not developing properly, and that's a concern for us. Babies that are born very small have much higher risks of heart disease, diabetes, high blood pressure, cardiovascular injury later in life when they grow up to become adults. So we don't want small babies. We also don't want huge babies. We want like average babies.
On Instagram then. I got a single dose of
Trexate?
Yep. Methotrexate to eliminate spontaneous ectopic. When can I start my third IVF cycle?
Oh, minimum of 3 months is recommended after methotrexate. So it takes about 3 months for the methotrexate to wash out of your system, so that's how long you should wait. Because it is chemotherapy, you don't want to be trying to do IVF with chemotherapy circulating in your body.
What are the miscarriage rates after a successful IVF transfer? Are you considering more high risk if you do IVF?
Yeah, so miscarriage rates are very center dependent. If you look at the literature, it's typically somewhere around 15 to 20%, which is kind of normal background rates. But there's often a lot of variation there. So I can tell you in our experience, it was always more like 7%. I honestly don't think we were doing anything magical. I just think it was a low, miscarriage rate. There are centers with higher rates and there are centers with lower rates, but I think it's realistic to expect somewhere between sort of 5 to 10. 15, 20 seems awfully high. I just haven't seen it in our practice, but we're also not doing thousands of cycles a year. We like to keep our program to a size where we can make sure we're attending to each and every patient. So I think in the larger programs, they are experiencing higher rates of loss. But maybe that's because when you get that big, you're losing sight of some of the details. I don't know. But it is a risk. Are you higher risk by virtue of doing IVF? So this is a great question, and I applaud you for asking that. So thanks for sharing. Yes and no is the right answer. So no one technically considers IVF pregnancies higher risk, but as a practitioner of obstetrics, where I'm still taking care of my pregnant patients, I do treat my IVF patients with a little bit more attention to making sure something doesn't go wrong. We obviously shower everybody with a lot of attention and want to make sure that nothing goes wrong. But garden variety pregnancies, usually things will be smooth sailing the whole way through, whereas with IVF, things can turn on you, so you've got to be very vigilant to make sure you're observing them carefully. But we don't classify them as high-risk pregnancies.
It's really a lot. I don't know about a lot today. Is it possible to improve your AMH level with diet, supplement, or meds?
No, you can't improve your AMH level. Your AMH level is reflective of the number of eggs that are left behind in your ovary. It's only going to decrease. You may get little fluctuations up and down, but if you're a 5 or a 3 or a 2, you're not all of a sudden going to be a 10 next time or a 20 or something like that. So a low number is going to stay in that low range, and high numbers are going to generally stay in the higher ranges. And mediums are mediums, but you're not going to see something really low all of a sudden jump to a much higher number.
Looking into egg donations again, is there any guidelines for egg donors as to wait times to donate after receiving the COVID vaccine? Any information available?
So I looked this up the other day and I actually posted it as well. So we know that your COVID vaccine, from Pfizer at least, they studied this, showed that the peak of antibody production was at 28 days. So 28 days from the first shot. Assuming that you're getting your second shot around day 21 as you're supposed to. So with that in mind, the likelihood that your immune system is kind of in overdrive, producing a lot of inflammatory mediators and so on, and antibody, is probably going to begin to dwindle by the time you're 6 weeks out from the initial shot. That's just normal biology, maybe 2 months at most. So I think it's pretty safe to start getting your egg donor or yourselves ready anytime 6 weeks to 2 months after the initial shot is given to you. Because what they did show is that the antibody response stays elevated with a very small degree of decrease for up to 3 months after that initial 28-day period. So realistically, after a few weeks has passed by, you should be in a relatively safe zone where your immune system's not going crazy, it's just ready.
Hi, Dr. Victory. I'm supposed to start IVF with you next week. I tried emailing the office today and find out if I need to stop my Vizan and when my first monitor appointment is.
So we typically stop the Vizan right around the time we want you to start. So I will have the office reach out to you, Tarek. Just make a note of that name and we'll take care of that.
What are your thoughts on supplements to improve egg quality?
So we do know that coenzyme Q10, vitamin D, the fish oils, possibly inositol, NAC, turmeric if you have endo. There's a whole bunch of supplements, obviously folic acid, many different things. Iron, in fact, may have a role as well. All of these things can contribute to improving your egg quality. Again, keep in mind, if the problem is you are 44 and you're only making 1 or 2 eggs, these supplements are not going to turn your egg around from being genetically abnormal to being genetically normal. But we do want to make sure that we are able to address as much of the sort of peripheral health components of your egg as we can. So those supplements do help. And we support using those, and we actually have a naturopath on staff who we refer people to go over those supplements in detail.
Hi, Dr. V. Where
Hi,
will
Beth.
your U.S. clinic be, and when is it opening?
We are aiming for hopefully summer or fall in the US, and we will likely start in the Michigan area. So I don't want to give out too many details, but it'll either be Michigan or Ohio, and we will try to begin there and start with most likely an office and then lead that into an IVF center.
Hi,
Very
Dr.
excited about that.
Hi, Dr. Victory. Good evening. Do you recommend ERA and hysteroscopy before implanting an embryo?
So ERA is proven to be useless. There are actually 2 more studies being published that demonstrate that it's useless. So every single study of the ERA test, endometrial receptivity array, has demonstrated it has no value whatsoever. Their own study, which we reviewed in a previous Fact or Fiction not too long ago, about a month and a half ago, 2 months ago, demonstrated that there is no benefit to doing an ERA test. So do not spend any money on an ERA. It is totally useless. Maybe the only time you should do it is if your endometrium is very thin, you've tried everything humanly possible to thicken it, and it still won't thicken. So those cases, sometimes it's reasonable to check and see if their lining is receptive, not because you're looking for the timing of the receptivity, but because you're actually looking to see if there is a receptive status to the lining at any point in time. The best way to know that it's very bogus is that there's a study, and again, we reviewed this on a previous Fact or Fiction as well, that I just referenced earlier, which shows that a day 5 embryo can be transferred after 5 or 6 days of progesterone with the same outcome. The whole point of an ERA test is to try and tell you how much progesterone you need. Well, the studies without doing an ERA, where they've actually intentionally delayed people and done an extra day of progesterone versus not, showed no difference in outcome. So it really has nothing to do with the ERA test whatsoever. The other part of it was the ERA, and the other one was
Before implanting an embryo and a hysteroscopy.
hysteroscopy. If there's something wrong, sure, but I would do a saline infusion sonohystogram first, which is just the ultrasound version of it, and that will show you what you need to know. You don't necessarily need to do a hysteroscopy if there's nothing showing up on your SIS. On a hysteroscopy, the things we'd be looking for would be a polyp, a fibroid, something grossly abnormal about the lining of the uterus, or the shape of the uterus being abnormal. All of those things you can see on a saline infusion sonohystogram if it's done properly. So no, I don't think you need a hysteroscopy. And definitely no ERA. Please, I beg you, save your money. It's not going to help you.
Is the transvaginal ultrasound also used for medicated with injectable IUI?
Yeah. So if you're doing a medicated IUI, we do transvaginal ultrasounds to make sure we can see how many eggs you have and that they're growing appropriately. So that's an important part of what we do. We have to. It doesn't have to necessarily be done transvaginal. It can sometimes be done transabdominal, but it's not nearly as accurate and it's much harder to see. So typically we'll do it transvaginal.
From Instagram, can I continue intermittent fasting and low-carb diet during stimulation phase and retrieval?
No.
Or should I stop dieting before transfer?
Stop dieting and stop intermittent fasting. There's too many metabolic fluctuations when you're intermittently fasting to support that during something as delicate as the balance that we need, or what we call homeostasis, during an embryo transfer or stimulation cycle. Don't do it while you're going through your cycle.
Fragment, better to do in morning or evening, transfer tomorrow. Any tips?
Lots of prayers. So prayer actually in one study showed it would be helpful. Stay as calm as you possibly can, and fragment shouldn't make any difference when you do it, although it does burn and sting, so maybe nighttime might be better, but it shouldn't make a difference. Stay very positive. Your stress level does have a negative impact on your outcome, so that's critical. So you want a strong positive vibe going into it, and that should hopefully be helpful.
Would endo biopsy show any signs of endometriosis? No symptoms, but worried it's possible. When
No.
do you test for this?
No. So not endometritis. It says endometriosis.
And
Does it show endometritis or endometriosis?
metriosis.
Yeah.
Good old
So an endometrial biopsy cannot show you endometriosis at all. An endometrial biopsy is a scratch or a sampling of the tissue inside your uterus. Endometriosis, by definition, is that exact same tissue outside of your uterus, so there's no way to biopsy it.
At what follicle size do you recommend triggering for IUI with retrosol and Clomid?
So we do the same almost as we do for IVF, a little bit further out. So we'll usually go like 18, 20, sometimes as far as 22. There isn't a lot of agreement on how big your follicle should be before you trigger for IUI. So that's something I've been looking into, but it's really hard to find good data on that. We typically do it around the 18 to 22 mark, somewhere in that range. And right now, month after month, our success rates have been around the 20 to 22% rate for our IUI program, which is very good overall. So we're quite pleased with that.
Hello, Dr. Victory. I think you talked about this in a previous Factor Fiction, but what is your recommendation for number of IUIs to try before moving on to other options?
Yeah, so we do have a great Factor Fiction on that recently, actually. I think it was about 5 weeks ago. So if you're over the age of 40, you should not do more than 3. And if you are under the age of 40, you should not do more than a maximum of 6. Now, we typically, after 3 tries, even if you're under the age of 40, would offer some different treatment to you. So, for example, if you were using pills for your first 3, like Clomid or letrozole, we'd recommend you go to shots. If you had done shots for your first 3, we might talk to you about alternative options with extra therapies like intralipids or heparin or steroids or something like that, extra investigations to see if there's an immune problem or infection somewhere, or we might recommend surgery to make sure you don't have damage to your tubes or endometriosis. So typically after 3 tries, we want to recommend something different, but we know from a very well done study that we reviewed on Factor Fiction, more than 3 over 40, it's a 0% increase in success. So you're wasting your time and money. And more than 6 under 40, same thing, you're wasting your time. It's not going to work.
Is natural conception or embryo transfer impacted due to a retroverted uterus?
No. So a retroverted uterus is that upside down uterus I was talking about. So if your head's here and your feet are there, normally your cervix would be here and the top of your uterus there, and it'll be pointed up towards your head, right? But in some women it's tilted down, in some women it's tilted up, and in some it's completely flipped over backwards, which is retroverted retroflex. Aside from the fact that it makes sex painful and can be a marker of endometriosis, it has no impact whatsoever on anything.
Transfer tomorrow. Allergies are bugging me tonight. Stuffy nose, itchy mouth.
Oh.
Should I take Reactin or wait it out?
No, you should take Reactin because your immune system needs to be quieted, so you don't want your allergies in overdrive. In fact, if your allergies are really bad, I'm not sure I'd recommend you go ahead with a transfer. We try and minimize that usually.
I've done a few injectable IUI cycles where I've consistently produced 3 mature follicles. Is it safe to say that I would respond well to IVF? I'm 39 and considering IVF.
So that's an impossible question for me to answer without having the rest of your file. So I need to know what your antral follicle count is, the number of eggs at the start of the cycle when they're still small and you haven't taken any medication yet. I need to know what your AMH is, probably a little bit about your FSH, your body mass index, your overall health. Are you a smoker, a drinker, so on. So there's a lot of factors that going into predicting how you will do. Certainly if you've tried several cycles and you've had 3 good eggs, there's a reasonable chance you would do okay with IVF. But again, I need to know what the numbers are and what the data shows, and critically how many eggs are there and what your hormone levels are at. So it's impossible to answer from the information you've given me.
What type of fertility drugs do you recommend for IUI? When do they get started?
So IUI comes in 3 flavors. So number 1, you can do natural. You don't need any meds. So we're going to use your natural egg. We're going to wait till it's ready to release. You should take an HCG shot. That's yet again another one of our factor fictions. And that will improve your chances of success. And then you can do your IUI usually 24 hours later. Number 2 is to take pills. So the pills are either letrozole or Clomid. They can stimulate some extra egg production in some circumstances, more so with Clomid than letrozole, but nevertheless they both do. And then you go ahead and you do your insemination after we trigger you, or you can wait for a natural trigger. And so now you've taken oral medications. The third approach is to do the injections at a much lower dose than we do for IVF in most cases, to try and get those 2 or 3 eggs, understanding that you are increasing the chances of success, but at the cost of increasing the chances that the patient can end up with more than one baby. What's most important in deciding those things is A, what have you tried before? B, what can you afford to do, because the shots are quite expensive? And then C, what do you want to do? I mean, we give you all 3 of those options, and I do this for every single patient. And then I say, here are the chances with each one, because natural is going to give you about an 8% chance. The pills are probably 10 to 15, and the shots are in that like 20 to maybe as high as 30% rate, typically more like 25. So we'll give you those numbers. We'll explain the cost, because natural is obviously free for the meds and so on, because there are no meds. The pills are only about $100 plus you need the shot. And then the shots are really quite expensive. It can be anywhere from a minimum of about $1,000 out to thousands of dollars. So we give you the information you need, and then we support your decision-making process. We never push you into anything, and that's really critical. I'm a big believer in making sure that we don't push our patients, but rather educate you, give you the information you need, and then let you decide what's right for you to do. I'm not qualified to decide what's right for you. I'm just qualified to educate you on what you can use to make the right decision for yourself.
Does endometriosis contribute to low iron, and are there any non-invasive ways of knowing that could be the cause? Endo was treated with surgery.
So I'm not familiar with anything that says endo causes low iron, although typically patients with endo have heavier periods, so you probably would have low iron. And there is no way to know if a patient has endo aside from doing surgery. So there's all sorts of tests available. I'm actually working with the group right now to check out this one test that we think may show some promise, but the bottom line is currently no one has anything that demonstrates that there is a model or a method available to detect endometriosis without doing surgery. You must do surgery to detect endo.
I was given letrozole while doing IUIs. Can I continue to take this until next IUI? Not planned yet. If so, how long? What's the maximum time you should take it for? Thanks.
You can take letrozole indefinitely. There's no risks to taking letrozole, especially if you're PCO. You should take it because we don't want your cycles getting irregular. So yeah, there's no risk to taking letrozole. You can take it as many times as you want.
Is there augment treatment to improve egg quality?
Augment as in we take a chunk out of your ovary and siphon off the stem or original mitochondria and then inject them into your eggs to boost them. So that's a company called Oviscience developed that, if that's what you're referring to, the augment procedure. Categorically useless. That company folded. I don't even think they're in existence anymore. The people that were doing it were charging an arm and a leg for it, like 10 grand, saying this was making the difference and it wasn't doing a thing. One individual in Toronto in particular did quite a bit of it, gained quite a bit of notoriety for it, and was just taking money for nothing. 10 grand US to do that, in addition to the cost of the IVF. We tried it with the company. They gave us 5 free tries. 1 of the 5 patients got pregnant. So it does not work. It's useless. Don't bother with that.
Doctor, I have PCOS, been trying to conceive for the past 3 years, and I was prescribed letrozole 5 milligrams, but my follicle stayed at 11 and was shooting for IUI, but couldn't do it this month.
Right.
What should I do?
So there's a lot that can be done. So number one, you just try again. That's a great question, by the way. It's a fantastic question. You know, all these years, no one's asked us no one's asked us that. So you can try again, and that's reasonable. Number two, you could try a higher dose. You can go up to 10 milligrams with letrozole. So either 3 pills or 4. You can do 7.5 or 10. You can take supplements. So inositol, NAC, coenzyme Q10. There is some evidence that taking DHEA may actually boost your response, and so do steroids. The mechanism is quite interesting, but there is a guy in the States that has this whole theory saying that you actually need to give extra androgens to these over-androgenized women, and that it'll actually set things back to being correct. And he's got some studies that support that. So that's something you could try as well. Metformin will be helpful, so that's something to consider. There's some evidence that the fish oils can be helpful, so that's something. And then, of course, healthy diet and exercise with significant or substantial weight loss if your body mass index is elevated, because that's probably the number one risk factor for failure.
Does Lupron shrink endometriosis?
It'll stop endometriosis from developing more or growing. It can cause regression of the small little spots. So I don't know that I'd call that shrinkage, because they don't shrink, they just kind of go quiet. Once the Lupron wears off, they can come back. If you're talking about the cysts of endometriosis, no, it doesn't do very much for those at all.
If you know you have fertility issues and you just have a baby but want another, do you need to wait that recommended 1-year period before seeking treatment again, or can you try via specialist?
Yeah, that's a good question. So I think that's very heavily dependent on what you've done and who you are in terms of your risk factors for infertility. So as an example, if you did IUI and you're 42 and you only want to do IUI, yeah, you should be trying again right away, because your chances are not high. So you want to capitalize on time as much as possible. So breastfeed for 6 months, jump right back into another cycle, start. If you did IVF and you're 33, yeah, I mean, you probably hopefully have some banked embryos. And as long as your ovarian reserve was okay, it's not going to be a huge difference between the time you're 33 and you're, say, 34 and a half or 35. So I'm not worried about those patients. And then there's everyone in between. So you do need to individualize. So I think it's certainly worthwhile to reach out to us as REIs and say, hey, doc, I had trouble before. Here's what happened to me. Here's where my numbers were. Here's what I did. Here's how I got to my baby. What should I do now? I want to try again. And we can kind of guide you through that process, or at least what factors to consider in making that decision effectively and appropriately. So reach out. That's a great physician consult, and a good one for us as we kind of do a flow chart for you and tell you where you should be at and what you need to think about in terms of your risks.
Your new ultrasound technician, Debbie, is awesome.
Well, thank you. I don't know if Debbie's watching, but Debbie, if you're watching, you've been here 2 days and someone already thinks you're awesome. So good job, Debbie. That's amazing. I love the feedback, and thank you for that, guys. That's incredible. Debbie is our newest hire. She is joining us as a full-time ultrasound technician. So now we can do all of our scans here: obstetrics, gynecology, fertility, everything, thyroid, breast, even if you have blood clots, we can do it. So we've got all sorts of cool stuff going on here. So it's pretty amazing.
High DFI can be treated by supplements?
Yeah, so if you have high DNA fragmentation indices, that's DFI, vitamins and supplements will help. They will not help if the problem is coming from something that you are doing, smoking, drinking, drug use, or you are obese, or you have a terrible diet, or brutal diabetes, or something like that. So there are cases where it's not going to be cured by supplements. Unfortunately, all too often, patients get hooked on the idea that there is some natural trick or twist or supplement or whatever that we can use that just kind of overcomes all of these other things that they're going through. And as much as I fervently wish that that were the case, because it would make our job so much easier, that's actually not the case. So yes, it'll help, but you got to make sure you're doing everything else to make it work as well. So things that help are cold therapy. Don't wear anything tight. Definitely don't get them overheated. Avoid pressure against your testicles. No smoking, no drinking, no drug use, loads and loads of vitamins. All of those things can be beneficial. Is it going on and on?
Oh yeah, like
It's crazy.
it's busy.
We may need to give them the extra 10 minutes. We got 1 minute to go, but I'll stay on a few minutes extra.
My NAC says not to exceed taking for 24 weeks.
Yeah.
What is your opinion on duration of taking NAC?
Yeah, someone mentioned this the other day that there was some kind of concern about renal damage. I'm not aware of anything that says that. It's literally an amino acid. So unless you're taking mega doses of it, it shouldn't do anything to you, but I am going to ask Kinga to look into that. Kinga, if you're watching, the world's greatest pharmacist, then I need you to tell me if more than 24 weeks of N-acetylcysteine is a problem. Having said that, guys, it's mainly used for treatment of endometriosis suppression, and it's also used to improve your egg quality when you have either endo or you have PCOS. So once you're pregnant, you don't really need NAC anymore, so it's not necessary.
Can someone who had a myomectomy not have vaginal delivery?
So theoretically, if they cut into your uterus and open the uterine wall, in particular if they entered the cavity, the inside of the uterus, you cannot. For me personally, I'm a zero risk kind of physician, so I like to make sure that all of my patients do well. And so I try and avoid anything that's risky. So the risk is that if you're in natural labor and you've had a myomectomy, your uterus can actually tear open at the site where the myomectomy was done. If that happens, the bleeding is torrential. You are at risk of losing your life, and your baby almost certainly is at risk of loss of its life or severe damage. So to me, it's not worth it. So I would always tell my patients, if they've had an abdominal myomectomy where I had to cut them open and kind of dig into the uterus to get the fibroids out, that I will not let them deliver vaginally afterwards. And I tell them all that ahead of time and document it and everything. If it's a small little fibroid, that's a different story. But if you're taking out 4, 5, 10 centimeter fibroids, that kind of thing, yeah, those ones, even a 3 centimeter buried in the wall, you're definitely going to need to have a C-section for those cases. Yeah.
What does it mean to have thyroid antibodies, and how is it treated? Thank you.
So sometimes people's immune systems attack their thyroids, so you're actually producing an antibody against parts of your thyroid tissue. So there's two main kinds. There's antithyroglobulin antibodies and antithyroid peroxidase antibodies. So the thyroid peroxidase ones are a little bit more serious. The theory, and it is a bit controversial, is that they increase your risks of failure and almost certainly increase your risks of miscarriage. How do you get them down? So pretty much the only way to reduce them is actually by overdriving your thyroid a little bit to make it more active. And you'll frequently see the antibodies go up when your thyroid is underactive. So by correcting the thyroid function, the antibodies should come down. In some cases, it's actually very difficult to eradicate, and we're not that good at doing it. People have tried selenium, they've tried steroids, they've tried vitamin D, vitamin C, calcium. There's a bunch of different stuff that's been tried, but realistically, not a ton of stuff really shows a lot of promise in that area. So it's mostly just overdrive the thyroid with thyroid hormone to improve its function.
Fresh transfer or frozen transfer for male factor? I was told from blood work I don't need genetic testing.
Yeah, so genetic testing is only based on your age. It has nothing to do with blood work, so I'm not sure why they said that. So I'm a big proponent of doing frozen embryo transfers. The current body of evidence definitely suggests that they are A, safer, and B, probably more successful. So we are right now getting the highest success rates we've ever had in my career, at least so far, and we are doing all frozen transfers. Having said that, there are cases where it should be done fresh. So low egg yield, less than 2 or 3 eggs, that should be a consideration for a fresh. If you have had a cycle where you're only making 1 egg because you're doing a natural cycle IVF cycle or a mini IVF cycle, those are both indications to consider doing a fresh embryo transfer potentially. And if you failed frozen embryo transfers before, then again, that might be a reason to consider doing a fresh in your next cycle. And even sometimes doing day 3 instead of day 5. Places that stick to one hard and fast rule, they are destined for failure because this is biology. So you got to be willing to be flexible or else you're never going to find all the answers.
I haven't seen you since February 2020. Then COVID shut things down.
Yeah.
Do I need another referral to see you? I want to try a natural cycle one more time now that your clinic is running. I'm 40 with low AMH.
Yeah, you are still within the year, so you could probably just call up the office and say, hey, I got scrambled by COVID, and we'll take you back quickly, sure.
I had IVS last month, but I had 4 egg and 1 boost stick egg, but it was abnormal. My AMH is 0.27. Do you think another IVF will help me?
Well, based on tonight's topic, you only have an 11.5% chance of doing poorly again. But again, I would need to know all of the other elements in order to figure out what to predict for you and give you a fair assessment of what your chances are. So we would need to know how well you did from that cycle, how many embryos you produced, and so on. Reach out. I'll be happy to do a consult with you. And go over it and figure it out. So yeah, it depends on a number of factors as I outlined earlier in the show. Those things are critical to determining what your success rate would be trying again. But it's definitely possible, and I certainly wouldn't take hope from anybody considering 88.5% will do better the second time around than they would the first. You have to understand for us, as much as I hate admitting to this, because I feel bad doing it, but the reality is that we learn something every time we do IVF. I learn how you're going to respond to this dose. I learn how you're going to respond to that medication. I learn how long it takes you to respond. Maybe I should try this protocol instead of that protocol. We go with what we think is best, but because it's biology, there's no way to know ahead of time for everybody. So sometimes it's experimental for us too. We have to figure out what's going to work for your body. Unfortunately, I appreciate the fact that that is phenomenally expensive. The reality is we don't have a way around it. There is no way to predict how someone is going to respond to this dose or that dose, or to know exactly which protocol is going to be best for them. That's being looked at a million times. No one can figure that one out. We just don't have that technology or that knowledge yet. Last one?
Yeah, you can say that.
Okay, we'll go to 9:15, and then my wife's going to start sending me death threats.
Okay.
We love you, Wendy. Everybody send a shout out to Wendy. Wendy, we love you. And my sister, name is Venus. Cool name, right? Venus Victory. So Venus, happy birthday. We love you. Thank you for being the best big sister ever. Love you very much, and I hope you had a great birthday.
Do you check tubes before starting IVF?
We always check tubes. You have to check tubes because if your tubes are damaged, it's a 50% reduction in your success rate. So you need to know if your tubes are damaged. We check it for everybody.
How many months after poly P removed should you do another saline sonogram to check if it has reoccurred?
I need to get a fertility specialist to read these. How many months after a polyp has been removed? Not a poly P. So after a polyp is being removed, we would check immediately the next month. So there's no reason to wait. So you can check with a saline infusion sonohistogram right away.
Don't start that. PGS normal loss, no reason found except MTHFR and PAI1.
Yep.
4G.
Yep.
Did all testing. What are my odds of having another loss?
So you should be taking the appropriate folic acid, and then you need to be on heparin and anti-inflammatory stuff. So that'll help you. Yeah.
Is it safe to take NAC during pregnancy with
And
blood
aspirin.
thinners? Seeing mixed reviews.
Again, I've somebody asked me about this before. I am not aware of anything that has said that NAC interferes with blood thinners, so there is no reason. And actually, I think Kinga looked that up for us, said there was nothing that she could find either. So as far as I am aware, there is no evidence that says that NAC and blood thinners are a problem. Fire away.
Is low carb diet okay after embryo transfer? I have PCOS
Yep.
and had
Yep,
gestational diabetes. Yeah. Okay.
yeah, for sure. Stay on your low carb diet, it's helpful. High carb diets cause inflammation, and we want to reduce inflammation always with fertility. So if you can stay on a low carb diet, stay on a low carb diet. That's great.
What are your thoughts about strict keto? No carb, no sugar prior to stim?
No, way too much inflammation. Don't do that.
What is your view on DQ alpha genes and the impact and treatment in fertility?
It's really controversial, and I've looked at that before. There is some evidence that DQ alpha genes can have a very significant impact, but no one is 100% sure on that one, so it's really hard to know. We certainly don't test for it. It's too early in the knowledge of DQ alpha gene subsets to know if it really makes a difference, because I did take a look at this, I think it was about 2-3 years ago. And at that point in time, there was a lot of equivocal data, with one study saying it made a difference and the next study saying it didn't. So we don't know yet.
When doing a modified natural FET, does it matter when you're transferring in your cycles, especially considering receptivity?
Oh, for sure. Yeah, it always matters. You got to make sure you're transferring after the appropriate time of progesterone exposure, whether it's natural or stimulated. You got to make sure it's at the appropriate time. So you can't take a day 5 embryo and stick it in after 10 days of progesterone. You actually just put it into a uterus that got exposed to birth control. So you need to make sure that the duration of progesterone exposure is appropriate, but the ERA test does not predict when that window is. They're actually claiming it's a 6-hour window, and there's categorical data that we've reviewed on the show that shows that even a 24-hour window makes no difference. So don't bother with the ERA test, but yeah, you got to make sure with whatever type of embryo transfer you're doing that it's within a reasonable time frame.
Do you recommend your patients who've had ectopic pregnancies with
Methotrexate, yeah.
as treatments to get HSG done before another cycle?
So if you've had a previous ectopic, if you're trying to do something like IUI, yeah, you should, because you want to know if that tube is open or not. And that's important to know. If you have had a previous ectopic and you're doing IVF, there's no reason to necessarily recheck your tubes unless your ectopic was because of a history of an infection like chlamydia or gonorrhea, because then you're at risk for tubal damage, which can reduce the chances of success. Having said that, you do want to take a very careful look on ultrasound at the tubes, because if you see swelling there, that's not good. So you need to make sure you know about that ahead of time.
I think this is the last one because I see a lot of cake, happy birthday Venus posts.
Oh, good.
This is the last one.
Yeah.
On Instagram.
Okay.
Secondary infertility. Sperm count good, tubes open, 35. Will a laparoscopy surgery help me get pregnant?
It depends on what your cause is. If it's secondary infertility and it's unexplained, then there are 4 things that will work for you. So it's pills and insemination, shots and insemination, IVF, or surgery. Those are the only 4 things that have been proven to be beneficial. So yeah, it could be beneficial for you. Keep in mind, no one's operating during COVID, so it's tough to get surgery right now. Our hospital just basically shut down to anything reasonable as far as surgery is concerned. So it's going to take months, if not at this point, years for us to get back to where we were before. So yeah, it's going to take a very, very long time. But yeah, if the world was perfect again, I frequently offer that to my patients because I think it may work. Okay, we are almost at 9:15. You still have millions of questions, eh?
Yeah.
All right, guys. So we're going to sign off because I can't stay on forever as much as I would like to. So happy birthday to my big sis. Congratulations to my kids who have all done awesome in their school. Congratulations to all of you who have warriored on through your fertility processes and journeys. And please know that we are there for you. We want to help you any way that we can. I get loads of people that just reach out to get advice, and I'm happy to do that, and I don't charge for it all the time. So if I can help you in any way possible, that's why I was given the opportunity to do this job, and I take that seriously. So hopefully you enjoyed your fact or fiction for tonight and the Q&A session. Hopefully our tech worked, and this is going to be the new model for us. Make sure you like, comment, and subscribe, and if you have any questions or comments, make sure you post them. We want to make sure we're going to see that. And very soon we're going to do a new video on embryo math, which should be coming out, where we actually talk about the calculations of knowing what to expect going into a cycle. So I think you'll enjoy that. And then we're going to do one on your sex life when you're doing fertility treatment, because sex is always a hot topic. So we will talk to you guys soon. Have a great night. We'll see you again.